Hello, we are going to talk about goiter. Goiter means enlargement of a thyroid gland. Goiter are present in up to 9% of population. It is more common in women than men. Most commonly, a goiter is noticed as a cosmetic defect by the patients, and sometimes the patient discovered the goiter um, when their friends or neighbors told them that there is a swelling in the neck. Usually, goiter is painless, but if the patient feels discomfort or pain, it might be due to a viral thyroiditis or cyst hemorrhage. You know that thyroid is surrounded by many structures, tubes as esophagus, trachea, nerve as recurrent laryngeal nerve, vessels as internal jugular vein. So when thyroid enlarged and started to compress esophagus, leading to dysphagia, trachea leading to dyspnea, or compressed recurrent laryngeal nerve leading to hoarseness of voice, and internal jugular vein as in cases of retrosternal extension leading to congestion of the face, congestion of neck veins, and blacking out fainting attacks on stooping forward. Goiter could be diffuse, nodular, or tumor due to adenoma, carcinoma, lymphoma, or miscellaneous as in sarcoidosis or tuberculosis. Diffuse goiter as simple, autoimmune, thyroiditis endemic. Simple diffuse goiter as there is no underlying cause, gland is smooth and soft, also there is normal function. Autoimmune thyroid disease as Hashimoto thyroiditis and Graves, the gland here is firm, diffuse goiter, variable size, and per week could be heard as in the cases of Graves. Thyroiditis as viral thyroiditis, where there is pain in the gland referred to the jaw, and it is associated with increase in the T4, which is a transient increase. Also, there is increase in inflammatory markers as C-reactive protein. Iodine deficiency goiter, it is not a problem in Egypt since they started to add iodine to salts, but there is still a problem in many areas of the world. So when this happened, leading to decreased senses of hormone, leading to increased TSH by feedback mechanism, leading to finally thyroid gland multiply and divided, leading to goiter. Nodular goiter as multinodular goiter, solitary nodules, renal thyroiditis. Multinodular goiter, which is common among elderly patients, usually euthyroid, hyperthyroid, or borderline. Multinodular goiter is associated with esophageal compression symptom as tracheal and esophageal compression, which is mentioned before, and sometimes it is associated with retrosternal extension. Solitary nodular goiter, solitary toxic nodule are uncommon and may be associated with T3 toxicosis. The majority of such nodules are cystic or benign, but malignancy should be considered in any solitary nodules. So the challenge here is to pick up the minor malignant cases from the majority of benign cases. So you suspect malignancy or thyroid carcinoma in any case with rapid enlargement of the gland or associated with lymph node or occasionally pain. Also, the presence of risk factors as previous neck irradiation, long-standing iodine deficiency, and occasional family cases. Nodular goiters, fibrotic goiter, which is rare. The gland is woody, hard, so it is difficult to distinguish cases from carcinoma. Presence of systemic symptoms or of inflammation and elevation inflammatory markers is a good point, but also we need pathological assessment to distinguish this pathology from carcinoma. How to assess a case of goiter? This done by clinical examination, laboratory test, and pathological assessment. During clinical examination, you should press on the consistency of the gland. Is it hard or firm? Is it diffuse enlargement of the gland or nodular? Is it single nodule or multiple nodular goiter? Is it if there is puree? If it is tender gland? If you can feel the lower border of the gland, so you can exclude the retrosternal extension. Also, the position of trachea, if it is shifted or not. Presence of lymph node, as it is present in malignant thyroid disease or in some cases of thyroiditis. Investigation by doing a thyroid function test, the TSH, free T3, T4, and thyroid antibodies which are present in cases of Graves, for example, and Hashimoto thyroiditis. Ultrasound, which is helpful, it can give an idea about small nodules which are difficult to be felt clinically. Also give information about the presence of cysts, presence of calcification. Scan can give idea about the uptake of the gland, if there is a cold nodule as in the malignant thyroid nodule, if there is diffuse increase of the uptake in Graves, multinodular goiter, solitary nodule, or decreased uptake as in cases of thyroiditis. X-ray also can be helpful, could be helpful in cases of retrosternal extension. This is normal X-ray, and this is a case of retrosternal extension. Fine needle aspiration guided by ultrasound in patient with solitary nodule, also in patient with dominant nodule in multinodular goiter. By the end of this presentation, we focused on the clinical presentation of the goiter, types of the goiter, and how to assess a case of the goiter. Thank you.